Welcome back to the Gary Sutton Show, our final hour here of the week. It's been a quick week. It really has. So many times you think the first week in January is going to be a drag. Yeah, you're coming out of Christmas, you're coming out of New Year's, and you think, oh, man, I'm starting that great time that leads up to Valentine's Day, and then after that you're making a run up to the spring, and you know what I mean? But it's been a quick week. It's been a fun week, and there have been a lot of things going on. I want to check in next with Danny O'Connell, who's a healthcare expert. One of the things that's happened this week is our United States House of Representatives voted down Obamacare. Yep, they repealed it. And they sent it to the president along with what the Senate had already done. And the president is going to surely veto it. But I wanted to get deeper into Obamacare right now. You hear a lot of different things about it. Where is it succeeding and where is it failing? And I thought I'd go to a guy this morning that deals with this kind of thing. He is Danny O'Connell, and he's a healthcare expert. And he joins us here on the Gary Sutton Show. Danny, good to have you on the show. Good morning to you.
Good morning. Thanks for having me.
Danny, I want to try to take all the politics out of this if I can and sit and look at Obamacare, the Affordable Care Act. So if I were to take the politics, I should take the name out. The Affordable Care Act. From as objective a point as you can look at it, where is it succeeding right now and where is it failing? We saw the House repeal it this week again, like the 60th time they've done it, or 65th time, whatever it's been. Where is it succeeding, first of all?
Sure. So where it's working is you probably have nationally somewhere around 1.5 to 2 million individuals who have some level of coverage where they probably did not before.
There's a number that many of the people who support it keep throwing out there. Maybe you can put this in some context for me, where they'll say 17 million people are now covered. Does that include like Medicaid as well as the number you mentioned, or is there something more to it than that?
Well, you have to throw that number out, and the number from this year you're going to have to throw out as well, because what that includes the people who had prior coverage who then lost it, or their plans were canceled due to Obamacare.
So in other words, they were forced to take those plans out because they were the so-called substandard plans, and then they had to replace them with the Obamacare plans?
Right, and some states allowed people to keep plans for a longer period of time.
Okay.
Some said, no, that goes against the spirit of the law. You have to take the new one. So in the first year, 8 million signed up, but out of 8 million, only 1.5 were actually net new policies. And then at the end of that year, only 700,000 of those were still in force.
Wow. So in other words, a lot of people hadn't paid.
Exactly, or they just canceled their plan because they got to the doctor. What do you mean I owe $6,000?
Okay, yeah.
I don't have that.
Exactly. So that 17 million, we could toss that out. And that does put it in some context for me. It makes it a little bit more understandable. So go ahead. I didn't mean to interrupt you, but it just kind of came to me, and I wanted to say it while I was thinking about it. So go ahead.
Sure. So that's where I would argue that it's working, is for those individuals. Some have seen a decrease in cost. However, with that, you have to look at what am I giving up as well. And now a lot of the individual plans, I would argue, are worse in terms of level of benefits and provider access than the plans that they were deemed substandard and that they replaced.
Is there a specific part of the population that is seeing a decrease in cost? I mean, obviously, if you're getting subsidies, you're seeing a decrease in cost. But overall, I mean, is there a certain group of people in our economy that are seeing that, or does it depend on the state?
Well, that's a great question, and it's kind of hard to make that blanket statement because it's this trade-off. What am I giving up now versus what am I getting? So, okay, we can lower premium by giving up copays, giving up benefits, giving up provider access.
Right.
So conceivably, if you're just looking at a plan-to-plan comparison, what I had before versus what I can get now, it's more expensive for the vast majority of people, overwhelming majority of people.
You know, when I look at this, I guess one of the questions that a lot of people have, and I'm trying to think of the things that I hear over and over again, and people say, okay, the president said I can keep my doctor, I can keep my insurance. That turned out not to necessarily be true. Not that it wasn't in every case, but in most cases, not to necessarily be true. And then people also said, my choices that I have now are much more restrictive in terms of the policies that are available to me. Talk a little bit about those two things and the truth or non-truth to those.
Yeah, that's very accurate, and that's only going to get worse. Because when you look at things like group plans versus individual plans, you know, a plan through your employer versus going out on your own. Before, the networks used to be very similar. You know, a provider would have one PPO network or one HMO network that they would offer. Well, because of all these things now have to follow these certain guidelines, the plans are very close in what they cover, So the only way for insurance companies to try to cut costs and live within the regulations is, okay, we're going to restrict and have a smaller network. A lot of providers, they may be in the network and they find out and then they don't want to take the plan, or they just say, we're not taking those individual plans anymore. The other thing that you're going to see in the changes are going to be with the prescription drug plans. And under these guidelines and how they're set up now, your prescription drug coverage is going to continue to get worse, meaning more prescriptions are going to not be covered, or you're going to be paying more out of pocket for your prescription drugs over time.
Again, why is that? That you're going to be paying more for prescription drugs?
Yeah, so when you look at the fact that all these insurance companies have to operate under this new financial model where every dollar you pay in, they have to pay out 85 cents in claims, and they cannot evaluate any risk whatsoever on these individual type policies, meaning, if your house is on fire and you call your insurance agent and say, I need a homeowner's policy, they got to cover you right then.
Right.
Same thing on the health policy. So that's naturally going to drive the prices up. So like in the state of Texas last year, Blue Cross Blue Shield had a $400 million loss on 367,000 covered lives.
Good grief. So
how are you going to make up for that? Well, okay, our only areas that we have control over now are our network and our prescription drugs.
That's amazing stuff. I'm sitting here thinking about back in 2007, 2008, the housing in this country where people, it's kind of a reverse thinking, where people could buy it but not be qualified. Here, you're not really qualified, or it's just kind of this random, I'm going to go out there and you're paying out these costs. I mean, there's not really any responsibility to it, is there?
There's not. And when you're talking about loss, I'm not talking about, okay, they paid out $400 million in claims.
Yeah.
It's $400 million above and beyond what they collected in premium.
Wow.
Which is mind-boggling.
Yeah, that is absolutely astounding to hear that. When you look at the promises, one of the promises was that we're going to save on the average about $2,500 for, I believe, a family policy, if I'm not mistaken on that. That's not the case. I mean, it looks like it's actually going up, not going down for most people. Again, people who are not getting subsidies, which is most of us, I think, in this country. Why is that? What's going on?
Yeah, so people, for lack of a better term, are now being penalized for being healthy. What happens is with the rating system, they created a new rating system, this community rating system, where it just looks at basically where you live and what your age is. So if I'm 35 years old, obese, heart disease, I'm paying the same amount as somebody who's 35 years old, exercises regularly, eats regularly. In the old model, basically, if you're that healthy 35-year-old, you could go out and get an individual policy and pay substantially less because you are at less risk for health conditions compared to the obese, smoker, all that type of thing. So now what they've done is say, well, that's not right, so we're just going to average everybody out. And then on top of that, you can make the argument, well, then the sick people are going to be better. But then on top of that, they created these banding, of which there's 3 different bands, and it gets a little complicated. But that banding has driven prices up for people that are younger, and it's driven them up substantially for people who are 50 or older. Your break even on the banding is anywhere from like 33 to 40. It's probably about a push. But then you have this community rating factor that's driving up the claims as well.
One of the things that I've read some differing numbers lately. I read an article the other day that said there are more young people getting into the policies now than there were before. And then I read that there's a shortage, an absolute shortage of people, and they're not able to support. Obviously, if they're not getting in, the money that's going to be transferred to the back end isn't happening. And I see groups like United Healthcare suggesting they might not be in future plans because it's not working out well for them. Your answer to that? Right.
Well, nowhere near enough young people got on the plan. Hopefully you'll see more young people get in the plans, unfortunately, due to the fact that penalties go up every year, and you don't realize what your penalty is for the previous year until it's past open enrollment, so then you got to pay a bigger fine the next year. To say more people are enrolling in the plan, well, that could be one more person than last year enrolled, so yay, we have more young people in the plan. But the reality is there's not enough of a drive of a large enough population of young people enrolling with lower claims. If I'm 25 years old and I wasn't buying something when it was priced at $150 a month because I didn't see the need for it, I'm probably not going to go buy it at $300 or $350 a month.
When you look at the trade-offs right now, there are a lot of people that say, well, we could take Obamacare, we could take the Affordable Care Act, and we can keep certain things. Like a lot of people say, well, pre-existing conditions, that's something that is a good thing, that should be in there somewhere. People say that generally. I wanted to get your thoughts about that, but also, is there a way of reforming this whole plan to make it work, or is it based on a faulty model? And if you were to reform it, what would be, because I haven't heard the Republicans really come out definitively. They hit different parts, but I haven't heard them really come out definitively with their own plan juxtaposed to that. So your thoughts about that?
Yeah, that's about a week-long conversation.
I know. But
we're almost getting to the tipping point of this thing where I don't think you could back out of it. It definitely needs to be reformed. The sad part is over the next 12 months, most of the nation is going to be faced with losing the plan that they're currently on, or a lot of people will be facing that. And that's because of the delays. If you remember in 2014, everybody's supposed to move an election year, so the president kicked back another 2 years and kind of gave us a reprieve. So now it's going to really affect a lot more people this next year. And that's where you can argue those statistics and say, well, look, now we've got 30 or 40 million people who went out and got coverage. Yeah, you probably do, but 35 million of them actually had prior plans that got dropped due to the law. In terms of fixing it, it takes everybody working together, and that's what makes it so complicated. One of the things we see argued is to actually have hospitals, instead of negotiating with insurance companies over rates and getting into this holding each other over the barrel, hospitals start actually pricing their plans and what the market allows, what in your area compared to other hospitals and peers, allow them to price, and then allow insurance companies to reimburse off of what's like a usual, customary, and reasonable charge, like what a lot of dental plans do. So, okay, hospital A, you may charge $1,000 for this. Hospital B, you may charge $750. But we, as a health insurance company, we're going to reimburse this based on what 90% of your peer group charges. So, if the average peer group charges $800 for this, then that's what we're going to reimburse those rates for. Now, yes, that could mean that people would be potentially paying more if they're going to the most expensive hospital or facility, but you would also have the market hopefully helping to drive down some of those prices for different services. It's like, okay, I go to the hospital, it's $100 for an Advil. No, thanks, I'll bring my own.
Yeah, thanks. Hey, I guess the question I want to ask, and you kind of led me to it, is why can't people be trusted to go shop for their own health care? I mean, I realize there are state laws, and I realize states kind of have monopolies a little bit, but I mean, what's so hard, and what makes it so different from, let's say, the car insurance that we go to purchase, or home insurance, or whatever it might be? We can go across state lines for any of that stuff, but we can't do it so much for health insurance. What's the rub?
Yeah, well, good question. So one, you've got the fine print. I would say, if you go get in a car accident and, okay, your deductible different from one company to another, or, something in your policy isn't covered,
right.
Hopefully that doesn't wipe you out catastrophically. If you go get diagnosed with cancer and you don't have the right type of coverage, you're potentially looking at just not getting treated, or how are we going to come up with $250,000? I would say that people are becoming more savvy. But the problem is every year these policies change, and part of that's due to the law. So once you think that you have a good handle on your policy, and I talk to people all the time, they say, I just renewed my plan. I go, well, that plan is no longer offered. Didn't you get a letter from your carrier? You're not on that plan anymore. And, they just didn't pay attention, didn't open the mail, whatever. And that's why we really advocate always working with an insurance agent, somebody local in your community, to help you navigate the system in this process.
I want to come back after this, Danny, and talk a little bit with you about the Cadillac tax. That's been put off for 2 years now, but again, it's been put off, not ended, for 2 years, and what that really is all about. And then some things you look at with regard to our death panels, the real thing. What about the death spiral of this whole thing? We're going to get into that with Danny O'Connell when we come back. He's a healthcare expert. We're talking about Obamacare and breaking it down for you on all sides of the coin here on News Radio 910 WSBA. Welcome back to the Gary Sutton Show on WSBA, our final hour of the week. Danny O'Connell, a healthcare expert, doing a great job this morning on breaking down the Affordable Care Act. Danny, I want to hit a couple other points with you here before we leave you today, and I really do appreciate you taking the time to share your expertise with us. The Cadillac tax, we saw where that is being pushed down the road, I guess, 2 years now, in the most recent omnibus bill, I believe. And so you're not going to have to pay that for 2 years. That's nice for the unions, but the fact is, when President Obama's out of office, that tax is going to come back, or maybe not, depending upon who makes it into office at that point in time. What's that whole thing all about?
Yeah, with regard to the Cadillac tax,
yep,
I really think that that's something that you're going to see go away. It wasn't indexed correctly, so essentially, in a very short period of time, that would have applied even to the cheapest of bronze plans. And so, I've looked at numerous studies, and I honestly believe that will be just kicked out. And you see that, and a lot of people aren't aware of it. I mean, almost monthly. And it's slowed down a little bit since the first years of the Affordable Care Act, but there are so many things that get dropped, moved, amended that people just aren't even aware of. It's unbelievable.
What are some of the most insidious and egregious things that you see in the Affordable Care Act that stand out? You hear people talk about death panels and the death spiral and all that kind of stuff. Address those a little bit if you can.
Yeah, that does exist. And out of your healthcare plans, you had what's called the PCORI fee, Patient Centers Outcome Research Institute. And the first year was $1, and then $2. They kind of increased it. And it was specifically designed to set up government research, hundreds of millions of dollars, to study the effects of if people are a certain age, at what point do you cover what conditions and what do you not. And we go and travel quite a bit up to Canada and do some research up there just on their model. And it was very interesting. I got in a cab. And, we asked the provider, this was a couple years ago, we asked the driver, what do you think of this health care plan in your system? And without saying a word, he pulled a letter out from his jacket, and it was a letter from his employer stating that one of your coworkers, 55-year-old male, needed the surgery, and the government said, we're not going to cover it. So if you want to help pitch in, we can payroll deduct for you to help them with the out-of-pocket expenses.
Wow. I did see something this week about Great Britain also with their health care system. When you compare, a lot of people say, well, Great Britain's doing it and Canada's doing it, therefore it's good for us to do it with the government-controlled health care. How do you respond to that?
With an example, I have a client who her son worked in Great Britain. And Great Britain's a good thing, a good model where you have government, but you also have private insurance. And so, she had a young son in his 20s, just need to get his tonsils removed. And after waiting over 2 years to try to get something scheduled, he signed up for a private health insurance plan, went in and had his procedure and was done.
Well, that's a good thing.
Right, and that's where you have to have this coexistence and have people have options and the flexibility. But had he just continued to wait on the government system, look at the VA. Look at the problems and the conditions that we have with the VA that we can't even get credible answers on. And that's what they're trying to force the entire country into, which that system's not working, clearly. We don't need to replicate that and make it larger.
When people talk about the death spiral, what are they really talking about here?
Well, kind of what we talked about previously with not getting enough young people in the plan. Yep. And when we first really studied this, we were kind of forecasting, probably by the year 2020, this thing is going to implode. But it looks like it's getting there a lot quicker. It's going to be very interesting by the year 2018 rolls around to see how, if this is still in force in its same similar method, how the plan and how everything is really unfolding.
Are you seeing in your experience very many instances of buyer's remorse, or maybe even, I won't say voter's remorse because we didn't really get a chance to really vote on this too much, but the buyer's remorse in terms of accepting Obamacare?
Man, it is tough, and we work with a lot of employers, and we'll go into employee meetings, and the rooms will be very divided, because you'll have people that will say, I was never for this, I was against this, it's being forced on me, and then you have the other side who are quiet or saying, you're lying, this isn't right, yada, 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 and there's some tense moments in there, and, one of the funny things, everybody with a Facebook account is a healthcare expert nowadays.
Right.
But I even have to turn off the TV because it's so complicated. Even when you listen to the news, no single individual in there has one answer, one solution. Otherwise, we would have had this fixed. And no one single individual really has all of the information because it's so complicated when you look at the insurance and the hospitals and the facilities. This was designed to lower our cost of healthcare. But in reality, all that it did was regulate and increase cost on health insurance, which is just a vehicle that we use to get treated.
Right.
There's a cause and effect relationship. Why are my premiums going up? Well, for these reasons. Well, we just did not address anything to do with why my insurance premiums are going up, and we just kept layering tax upon tax, which is driving up the premiums.
And so healthcare wasn't addressed as much as the health insurance, and thus we maybe have not as good health care as maybe we had before. Is that a fair statement?
That's a very fair statement. And in actuality, your providers, your options out there in the marketplace have been very restricted compared to where they were 5 years ago.
And the networks that you get into are much more restricted, and the things you can do are much more restricted. Finally, do you see us going to a single-payer system? Let's suppose that this time next year we have President Trump about to take office, or President Cruz, or whoever it might be, just for a what if. I'm not whatever name you want to put in there. And the Republicans, the first thing they're going to do is go out and they said they're going to repeal Obamacare. And of course, a lot of these guys like Cruz said first day that'll go right out the window. So the big question would then be, then what? Then what? What would you see being put in place? I've talked to a lot of people a guy down in your neck of the woods, Diamond Physicians, Dr. James.
Yeah, they're a great partner of ours.
Yep, there you go. And they're doing like a catastrophic plan, and then you pay the doctor so much a month, and you can go in for unlimited visits, and the amount of money it costs for operations and drugs and so forth is much less. I mean, that seems like where we're getting back to the old days a little bit, where it really kind of worked. There are people trying that around the country. What do you see if they would go out, let's say this time next year, and Obamacare would go away, if they have the guts to do that? What would they put in its place?
Well, I think before you just start going in and making changes, the prudent thing is to really take a look at what is working and what's not, and get some of the best and brightest in all of the industry, from hospital, government, so be it, insurance.
And real doctors who are working on a daily basis, too. Thank you very much. Yeah.
What happened to us was that you had politicians just get together and pass something, and if you look, the vast language of this bill says subject to the discretion of the Secretary of the Department of Health and Human Services.
Right.
That single individual has more power and control over our entire healthcare system than anybody, and they can make ad hoc changes at any time that they want.
And don't have to even be an expert to do that. That's what's amazing.
Right. That's not responsible.
Yeah. Danny, I've got a caller here.
Was Sebelius. In overhead. She was the insurance commissioner from Kansas, which basically their regulations in the state of Kansas had forced them to a single-payer system with Blue Cross and Blue Shield, where there was no competition, and that was the only payer in the state, and their premiums continued to go up. And I think, and this may be getting a little bit off your point, but I think if you look at what was intended with this, if you carried it out, it would say, well, look, we tried it your way, and it didn't work, so now we're going to have to go to a single payer. So if we do nothing and there's a Democrat, you're almost forced into that single payer.
Yep. And that's and then people would say, well, why would you go to a single payer? The same group that gave you Obamacare, if it didn't work, why would you go to a single payer? The same group is now going to take care of that too. I mean, that kind of doesn't make a lot of sense. But let me get a caller here with you very quickly. Terry in Lancaster had a question for you. Terry, go ahead. You're on the show with Danny O'Connell. Go ahead.
Hey, thanks, guys. This show is fantastic, and it's actually really timely for me because I'm in a situation where I have a new job. I'm working for a small employer. They don't offer benefits. First time in my life I haven't had insurance, and I haven't gotten the straight answer on how much I'm going to get fined if I don't get insurance. I'm hardcore against Obamacare, but if the fine is $2,700, then it's a totally different conversation than if it's $300. So I was just looking for some clarity. I'm 33, no pre-existing problems. I make probably around $40,000, $50,000, and I have no idea how much I'm going to get fined. And
you're indestructible, right? At that age?
Yeah, exactly.
Okay, gotcha, man. Let's get an answer here from Danny if we can. Danny, go ahead.
Yeah, good question. So for this year, 2016, your penalty is going to be 2.5% of your modified adjusted gross income. So that just means all of your gross income calculated in there. If you've got, interest from investments, whatever, your salary, it'd be 2.5% of that. There is still time for you to go out and get an individual policy. And for somebody that's young, that's not taking a lot of prescriptions and doesn't go to the doctor very often, a bronze level plan, may be appropriate for you, kind of like what we were talking about with what Dr. James and what we do with them. So that may be something that you want to look at as an alternative when you do that math on that 2.5% penalty.
Got it, Terry?
Hey, great. Thanks, guys.
Thanks for listening in, man, and good luck with that, okay? Danny, I really appreciate you being with us today. Well, final word on Obamacare right now, where we stand with that whole thing.
The only constant is change.
Okay.
Change in your plans, change in your benefits. From year to year, do not expect your plans, your benefits, and your doctors to be the same, because they probably won't be.
And keep an eye on that carefully, right?
Yes, sir.
Danny, really appreciate you taking the time today. Thank you so much. You gave us a lot of information.
Have a great weekend.
You too. Thank you. Have a great weekend. Danny O'Connell with us here on the Gary Sutton Show. We're going to put that up at Facebook.com/910WSBA. If you want to go back and hear any of those points, Danny did a great job, I thought, of trying to break it all down, pro and con.